Good morning, everyone. It's very great to be here and great to see so many participants. So I'm going to be recovering some of the ground we've looked at, but just in a bit more detail to focus on deployments. As Arlinda said, I'm Deputy Director for Operations, and I'm also an epidemiologist. So there's two primary mechanisms for RST deployment. One is through the UK's and our membership of the Global Outbreak Alert and Response Network, GOAN, and we'll hear more about that later. And these deployments generally are to WHO country offices, WHO regions, where we work hand in hand with WHO and partners. And then the other one we've heard about is a bilateral request from an ODE eligible country or regional body. And then essentially we are, our team are working embedded in and with our partner public health institutes or ministries. But there are some other kind of nuances. So one thing is that we do have some joint deployments. This could be either with another UK asset, for example, the UK Emergency Medical Team, which again we'll hear about more later, or with another regional body or partner. So for example, could be a joint deployment with Africa CDC, for example. And then increasingly, actually, with the constraints imposed by the COVID pandemic, we've had, I guess you could call remote deployments. So where we've been working from a UK base or from another base, but engaging hand in hand as partner with the team wherever they may be. So that's a model that's been evolving by necessity a little bit this year. And you've seen this slide from Dan. So this is in a nutshell the cross-government notification and approval mechanism. Again, developed by our founders to have a streamlined process so we can rapidly deploy, but also make sure that all the right people are involved and considered in the discussion. So there's early warning and then a formal request either through GOAN or partner. Our director and myself and the team will assess the request, and we'll prepare a report to go across government, submitted to the minister for clearance. And then we enter into a kind of formalized procedure for continuous information sharing, so regular situation reports during the deployment. And then after the deployment, there'll be an after action review or debrief and an end of mission report. So we're trying to capture all that learning from the deployment. And this is just a picture of our deployments since, well, the beginning really, since 2017. So, and again, this map's not quite complete because it's constantly evolving, but you can see just an idea of the things that we've been involved with. So with Nigeria, meningitis, Lassa fever, COVID-19, Sierra Leone, waterborne disease surveillance, post-emergency, DRC, Ebola virus disease, Madagascar, pneumonic plague, Tajikistan, Nepal, COVID-19, a long engagement with Bangladesh in Cox's Bazar, focused on initially diphtheria, cholera, and now COVID-19. Philippines, COVID, Ethiopia, cholera, and COVID-19, and also EVD preparedness in Rwanda. And again, you've seen a similar slide. This is a picture of our core deployment team Specialties, and this is constantly evolving, and we're aiming to be responsive to the needs and interests of partners. So we hope to be able to expand this soon and have a wider range of specialties. But these are sort of the core specialties that we have represented at the moment. So epidemiologists, microbiologists, social scientists, clinical, infection control, data science, and logistics. And the team really can either deploy individually if there's a particular ask for a specific specialism, or jointly as a team. But we're a relatively small team, and we work very closely together. So there is a team approach, so we can draw on the specialties and the expertise of all the team members. And again, it's coming back to that beginning aim of having pre-trained and pre-accredited, and we base our accreditation on WHO standards of what's required in the field. So we have people who are ready to deploy safely and effectively at the highest quality within 48 hours. And then just to say again, we have, in addition to the core deployable team, full-time RST staff, we also have reservists who are sited across a range of UK academic and government institutions. Currently it's at around 30 persons, and also field epidemiology fellows, also again working within public health institutions in the UK. And these individuals receive the same pre-training and pre-accreditation, and we've developed arrangements and agreements with their employers and line managers to enable them to be released as needed, and to have a kind of on-call surge capacity should there be an additional requirement over and above what the core team can provide, or if there's an ongoing longer engagement that requires additional support. So I'll stop there. Thank you very much.